Sir, Dr. Amit and Dr. Vidya are senior residents at Lady Harding Medical College, Dermatology Department.
Okay, fine.
Good morning, sir.
Good morning. Good morning.
We are now live.
We are live.
Yeah, we are
Yes.
live now.
Shall I
So,
start?
good morning,
Okay.
respected faculty and dear friends. So, we are here with the second session. It will be Skin Infestations by Dr. Bhattacharya, Dr. S N Bhattacharya. He was professor and head of the department at Lady Harding Medical College and Ambedkar Medical College. He was medical superintendent also there. So, without wasting much time, I request Dr. Bhattacharya sir to please begin the presentation.
Good morning. Thank you all. So, without much ado, we'll start with this topic. So, I've been given the responsibility of covering cutaneous infestations, mainly scabies and pediculosis. But if there's anything else, please feel free to ask. I'll try and clarify to the best of my abilities. Okay, so we start with scabies. Scabies is originating from scabere of Latin, which means to scratch. It is a itchy condition caused by the ectoparasite Sarcoptes scabi var hominis, uniquely adapted to the human host. The mite which affects us cannot affect any other mammal. And similarly, when other animals carrying scabies mite adapted to that animal, they usually don't, infect us to form a full-blown scabies. So it's a different form that happens, which we call animal scabies. Okay, 1 minute, next. The morphology of the mite, it's a ovoid. It has a ovoid body. It is it's ventrally flattened, vertically convex on the dorsal aspect, 4 pairs of legs, no head, no eyes. It is just one big body with legs, 2 pairs going towards the mouth side and 2 pairs towards the hind side. The males you tend to be smaller. They tend to be darker in color. And the 4th pair of legs may end in suckers. So the life cycle follows a rule of 3. So the eggs hatch in 3 days. All right, let's start with the adult. Adult lays 3 eggs per day, and the eggs hatch in 3 days to form the larva, which molts in 3 to 4 days to form a protonym, which over 3 days forms a tritonym, and that molts after 3 days to form the adult. And then the cycle gets repeated. The adult gets fertilized, the female mite, and it starts burrowing and starts laying eggs, 3 eggs per day, burrowing at 1 to 2 millimeters per hour. Mites can crawl on the skin surface 1 inch per minute, and skin to skin contact is required for about 15-20 minutes for infection to normally occur. So overcrowding, sharing common sleeping area, poor hygiene, all are promoting factors. Role of fomites is still not fully, settled, but we in dermatology usually advise the patients who have taken treatment to, treat or wash their clothes in hot water, keeping it for at least 20 minutes at above 60 degrees temperature. So then the mite cannot survive that. They're susceptible to dehydration, and their survival time actually is highly dependent on humidity and temperature. Mites seek out the most comfortable parts of the host anatomy, comfortable in the terms of secretions of sweat and sebum, which is good, and the thinness or the thickness of the skin, and temperature conditions. This usually leads to a unique distribution of the lesions. We will come to that. Okay, the disease progresses when, or it becomes symptomatic when the patient becomes allergic or develops delayed type hypersensitivity to the mite. or its metabolic products or its eggs. And these lesions can be produced other than burrows. All lesions other than burrows are a result of this development of hypersensitivity. And the itching, the main symptom, is also immunologically caused. So it is the host immune system which causes the itching, which triggers the itching, and it is the host perception of the itching which determines how much the host is disturbed by the infection and how symptomatic he or she is. The delayed type hypersensitivity uh, leads to infiltration causing papules and nodules, and this is wherever the antigens are deposited or left. And in a primary infestation, it may take 4 to 6 weeks to develop, but within days of a reinfestation, the recall immunity is able to manifest. So the first infection or infestation may leave the patient asymptomatic for a larger period of time. In established symptomatic cases, the mite population reduces dramatically due to mechanical removal of the mite by scratching or by killing of the mite by scratching. And this is a result of our immune response, the host immune response. Elevated IgE has been demonstrated, but what is its role is still not well defined. So, the primary symptom is intense pruritus, which intensifies at night. This the adult will tell you. In pediatrics, you might have to ask the child leading questions, or the parents will tell you that he's all the time scratching or she's all the time scratching. And the mechanisms of scratching are not well worked out, but all of these things on this diagram, all the entities on these diagrams seem to have a role in triggering itching. So first is the Th1 memory cell, then the toll-like receptors on each receptors, and proteases which are released by the immune cells, and complement activation, which attracts and captures more immune cells on wherever the antigenic availability is there on the body. So all these contribute to it. So we come back to the sites of predilection. So these are the areas: the axilla, the periumbilical region, groin, wrist, elbows, inner parts of the elbows, behind the knees. And if you can imagine in this diagram, the patient was clutching their hands together, then they would form a ovoid circle, which was called the circle of Hebra. This unique distribution is because these are areas which are not sebum rich. The mite avoids sebum rich areas. And these are areas where the temperature are favorable to the mite in colder times, colder periods of the year. So they tend to aggregate in these areas and burrow in these areas, leaving antigens and evoking the immune response. So this imaginary circle is the circle of Hebra. What does a burrow look like? The pathognomonic lesion of scabies is the burrow. So it looks like a erratic linear lesion with a globular end where the female mite is. And this is the trail along which the mite has gone in the stratum malpighi, eating ingesting the living keratinocytes in the malpighian layer. And this is the main source of its nutrition. And it goes in an erratic fashion because they don't have eyes or they don't have direction. They just go by the comfort zone, which is the area which is easier to uh, feed from and is more comfortable temperature wise. So they keep they keep burrowing. The burrow, when we identify it, can vary in length. So it depends on how much time that mite has been in that burrow. And the common sites usually are the wrist, the borders of the hand, the side of the fingers, genitalia, sometimes in small infants, the feet and the finger web spaces. Uh, Burrows are not commonly seen because by the time patients come to our OPDs, they have scratched out most of the mites and they've excoriated the burrows. Okay, papules can be erythematous papules or they are excoriated papules. They are seen again in the circle of Hebra area, all the areas of predilection where the mite has burrowed and left antigens. Okay, then there can be nodules. Nodular scabies is when the infiltration has become intense and 5 to 15 millimeter in size. Each nodule can be, and it is usually in the thin soft skin areas like scrotum, like uh, uh, umbilicus or a perioreolar region in adult females. Uh, the persisting mite antigen causes a intense infiltrate, which is predominantly mononuclear, and it can mimic a pseudolymphoma in appearance, both histologically and clinically. So it might require, in fact, it will require topical steroids to or immunosuppressive to suppress it after giving an adequate scabicide treatment. In infants, the scabies might also affect the scalp, face, neck, palms, and soles. So no part of the anatomy, the skin of any part of the body is no part is spared. So it can affect any part of the anatomy. And because in the infants the skin is thinner, burrows and the itching is more ineffectual, burrows will be easier to identify and demonstrate. But uh, the eyes see only when the mind knows what it is looking for. So one has to uh, this thing familiarize with how they expect to see the burrow and where they expect to see the burrow, and then the diagnosis becomes very easy to clinch. Okay, so most common presenting site in infants, even in our country, is papules, vesicles, and pustules. And pustules become sometimes bullae because of secondary infection with bulla forming microorganisms. Nodules, if the condition remains untreated for a long time, uh, the nodules can form even in infants, and then the distribution can be all over. Secondary eczematization and impetagization is common because of usually the hygienic circumstances of patients who get scabies is not ideal, and they tend to scratch, and the secondary infection usually supervenes. Now, because the picture can be confused, that is this, are we dealing with a bacterial infection, a primary pyoderma, a secondary pyoderma, or what? The examination of close contacts or caregiver is a must. That gives you the clue that you're dealing with scabies because they will have a typical adult scabies. Sometimes the scabies has throws up bullish lesions. In the pediatric population, you have to assume primarily or empirically that it is usually a secondary infection with a pus forming organism which has got toxins which separate the different layers of epidermis. Now, sometimes in adults or elderly, it may be a overlap with bullous pemphigoid or it may mimic bullous pemphigoid, and that can create a problem. Then a biopsy and immunofluorescence may be required, but this is not relevant for the pediatrician. Crusted scabies is another variant of scabies which are usually in index cases in small outbreaks or epidemic conditions. And this is when there are widespread hyperkeratotic crusted lesions all over, not necessarily all over, but some localized parts of the body which are cooler or favor the mite multiplication, and they're teeming with mites. So the mite load in those patients may be in the in terms of millions, and the it's called crusted because there is scaling, crusting, fissuring, and small amounts of epidermis break off, giving a dandruff-like appearance in other parts of the body. So I'll just show you a picture little later. Okay. So the causes are that there's a defective T cell response, so the itching does not manifest. So the patient is comfortable. And in poor hygienic conditions, the mite, multiplies in an unrestricted manner. Neurological disorders also do the same because the itch perception is modified and reduced sensation wherever there's sensory neuropathies or there's physical debilitation which does not allow proper excoriation or itching, scratching. Um, or there is mental debilitation where the response to itch is modified. All these conditions predispose to crusted scabies. It's better not to call crusted scabies Norwegian scabies because scabies has got a slight stigma that it implies poor hygienic conditions, poor sociological conditions, and unnecessarily attributing it to a nation uh, is not a good practice. So it's better to discard the term Norwegian scabies. So itching in crusted scabies is minimal or absent. We can see in this diagram. In this diagram, this is one of the patients who was admitted in our ward. She was actually a patient of psoriasis, misusing and over applying potent topical steroids, which suppressed her immune response and itch perception to such an extent that when she got scabies, it became crusted scabies. In addition to classical sites of involvement, lesions can be seen on other unusual sites also where the mite has got an opportunity to really multiply, and because it is not being excoriated out and it's not causing any itch. So it is graded into mild, moderate, and severe, that each of the uh, distribution is given a score of 0, 1, 2. Whether burrows are seen, whether uh, papules are seen, whether crusting is there, and so the total score winds up to about 10 to 12. And based on this, there's a graded duration of treatment. Uh, Fortunately, crusted scabies is rarely seen in the pediatric age group, except for patients who have malignancy and are severely immunosuppressed. So, pediatric patients with malignancy who are immunosuppressed are vulnerable to this condition. Complications of scabies. So, usually it is secondary infection and complications of that secondary infection. So, which my audience, I believe, will know much better than me. So, in the pediatric age group, all these complications of uh, gram-positive infections, micrococci infections, may occur. Even the trigger factor may be a scabies infection. So, diagnosis, how is it diagnosed? So, confirmed scabies is at least one of mites, eggs, or feces seen on light microscopy or any other methodology of optical visualization, high-powered imaging. So whether using a dermoscope, whether using microscope, whether using confocal microscope, so you can take it to higher and higher levels. If any of them demonstrate either the mite or the eggs or the feces, then the diagnosis is clinched straight away. Clinical scabies is diagnosed when we can demonstrate burrows, typical lesions affecting the male genitalia, or this involvement of, by appearance of lesions along the circle of Hebra. How is scabies treated? So treatment involves the treatment drug of choice remains permethrin cream because resistance to permethrin in scabies has not yet been proven. Topically applied overnight on 2 days, 2 occasions, 1 week apart. All contacts in pediatric age group, pediatric patient, there will be family contacts. So all contacts have to be persuaded to take treatment simultaneously on the same day, so that the mite in their household has got no place to go, without being confronted by the permethrin. Concern is that some people who are allergic to formaldehyde may develop a contact dermatitis or a contact sensitization to therapy, a recall dermatitis. But that should not be a problem in the pediatric age group, but it is definitely a situation in adults. Uh, there are, the debate is on that is tolerance developing, but usually what happens is that if all the aspects of all the areas where lesions are, or the whole body surface area is covered adequately for long enough, then there is usually no treatment failure. Particularly, just in case that some area has not been adequately treated, it is repeated on day 8, but by which the remaining eggs, which may have not been affected by the treatment, will have hatched, and even the newly hatched nymphs will get killed. This is pregnancy category B. Crotameton is an older molecule which gives relief from itch. It's not a very potent scabicide, but it's considered safe even in infants and children. So after treating with permethrin, if there's persisting itching, this is one option which will, and when you have a doubt that all family contacts have not taken simultaneous treatment, this is an option which might be kept in mind. Uh, Both the permethrin and the crotameton is usually not recommended in children, or in infants less than 3 months of age, where sulfur ointment is accepted as safe. It has to be applied overnight for 3 consecutive days. There has been no reported major toxicity except for local irritation, uh, and its efficacy is good. Uh, The other option is ivermectin, but the problem with ivermectin is uh, children less than 15 kgs safety. It is not recommended. So it will, if you are using it, it will be off label, and the responsibility of any bad outcome will be the pediatricians. So, and it's pregnancy category C, but it can be given in 200 to 400 microgram per kg dose, again on day 1 and day 8. It can be delayed, the second dosing could be delayed till by 2 weeks, instead of day 1 and day 8, it can be day 1 and day 14. Okay, so it's pregnancy category C. Now, scabies patient will need supportive treatment because even after you've killed all the mite and eliminated the infestation, the antigen may persist in the layers of epidermis where the mite has burrowed and left its traces for up to 2-3 weeks. Okay, so antihistamine will be required to give relief, or crotameton. Secondary infection may require antibiotics, which you will have to decide whether you want to give it systemically or locally. There may be dryness and scaling, or as a reaction, so you might want to soothe the skin with emollients later on. And in nodular lesions, after you have adequately treated the scabies, you might want to give a topical steroid, and this may also be used in eczematized patients in which there are no new lesions, but there is irritation and there's oozing and the dermatitis is left after the treatment of scabies. In crusted scabies, you will need keratolytics to help remove the crusts. treatment of crusted scabies, just one or two slides on that to complete the whole exercise. Combination with permethrin and ivermectin is considered because these patients, they have enough mites on their body to, you know, create a mini epidemic. So topical permethrin along with keratolytic agents or topical benzyl benzoate was what the CDC used to recommend, but benzyl benzoate is a entity which causes more eczematization and dermatitis. So permethrin is still being followed. Topical ivermectin has also become available, but exact recommendations are not there. It's not been approved by CDC or not recommended or by FDA. Keratolytic agents will be required as supplement to remove the crusts and ease the penetration of the permethrin. So this has to be applied daily for 7 days, permethrin, along with the keratolytic agent. In addition, oral ivermectin can be given, on days 1, 2, then 8, 9, then 15, then 22, 29. So it's almost a month of treatment with oral ivermectin given intermittently. The point is that this schedule does not, it does not get much compliance because uh, parents forget the dates on the children, don't take it, or patients become erratic in that course. So, according to disease severity, as we had discussed the grades of different types of or different expression of crusted scabies, grade 1 is given 3 doses of ivermectin over a week. Grade 2 is given 5 doses over 2 weeks, and grade 3 is given 7 doses over 4 weeks. So if you go back and see, these are 7 doses. First on day 1, second on day 2, third on day 8, fourth on day 9, uh, fifth on day 15, sixth on day 22, and the last on day 29. But it is a complicated regime, and people tend to forget, and compliance becomes poor. Itching may persist, as we have discussed, after scabicide treatment. So the cause could be either overtreatment or eczematization or a contact dermatitis to any of the treating vehicles or drugs. And the management is as per what is suspected to be the cause for persistent itching. So the prevention of all this is that the drug should be applied adequately, but not over applied and not under applied. So counseling the patient and the patient following what has been counseled are two important things which usually preclude the development of persistent irritation or persistent itching. However, antigens will persist, and if you have counseled the patient that some amount of itching will persist, and I'm giving you antihistamines for 2, 3 weeks more, you might need to take it. Take it as required. Stop as soon as you can tolerate the itching, and it will start fading. Patients are usually happy with that. The result outcome is that they will not come back again and again. Treatment failure usually is due to non-following of instructions or missing out on treating of contacts. Resistance is when you have not taken the optimum drug. That is unusual. Relapse or reinfection can occur, that you have to decide whether the patient has been inadequately treated or incompletely treated to result in a relapse. Reinfestation is because a patient's contacts have not been treated. Uh, Sometimes the persistent itching is a delusion, and that may require a psychiatric referral. This is usually seen in elderly patients living alone or living, in isolation. Uh, Sometimes there's a non-scabitic uh, reason for itching, and then the cause has to be treated. The delusion will require a psychiatric referral. Okay, now coming to pediculosis. So pediculosis is human infestation with lice. Lice belong to class Insecta. So they are not like the arachnid or the mites. These are in a different class of arthropods. And three species affect humans. Pediculus humanus capitis, that is the head louse. Pediculus humanus corporis, that is the body louse. And Thyrus pubis, or the pubic or crab louse. Now, so you can see that the adaptation of these organisms is so fine-tuned that the pediculus humanus capitis sticks to the head and does not go all over the body, and the body louse stays in the clothes and only comes to the body for a meal. And they don't overlap into each other's other zones because their requirements of blood, hair, and temperature conditions determines what they have been adapted to and where they are going to get located. So head lice, that is pediculosis capitis. So it's seen everywhere. Nobody is exempt. Children going to school with longer hair, which is, set in the morning and not disturbed till the evening, are more predisposed because children with shorter hair, whose hair keeps moving around, usually dislodge the lice if they get infested from their neighbor. So the peak most commonly is age is early school going or primary school children, sometimes secondary school children. Girls are more than boys because their uh, hair gets braided or gets set, or even if it is a ponytail, it is tied tightly and it doesn't get disturbed. So any lice captured in it stays intact inside. The infection requires head-to-head contact, and length of hair, overcrowding, poverty, and poor hygiene are predisposing factors. The adult female is a grayish white insect, 3 to 4 millimeter long. The male is slightly smaller. The claws on the legs are uniquely adapted for clinging onto hair. So, if you want to see if you see the head louse, you will find that at the edge of the last part of the legs have got claws. The eggs are cemented to the hair with the chitinous proteinaceous cement material, which is secreted by the female louse's accessory glands at the time of egg laying. So it is uh, laid on the hair shaft close to the scalp because they want the body temperature to ensure that the eggs have a good chance of hatching successfully. They are oval, flesh colored, about 8 millimeters in size, right? 0.8 millimeters in size, sorry, and have a lid, uh, which opens out when the nymph is hatching. The eggs hatch in 8 days. Once the nymph emerges, this becomes transparent and they appear white. Transition from nymph to adult takes 10 days. So in about 15 to 18 days, a egg will turn into an adult. So you can see the life cycle here, and you can see the different sizes. The female louse is the largest, then there's the male, and smallest is the nymph. This is when it hatches, it is smaller. It's about a millimeter in size. Then it becomes 3 to 4 millimeters in size. Clinically, it starts as asymptomatic. The itching is a prominent symptom, and secondary infection is the other symptom or the other presentation. That takes 2 to 6 weeks to develop. As again, this also follows delayed hypersensitivity, sensitization timing. And recurrent infection or a repeat infection, the itching can start within 24 to 48 hours because it's just a recall of the uh, immune response. So the itching is again, like scabies, triggered by the immune response. The secondary bacterial infection is usually gram-positive micrococci, and it causes fever as well as lymphadenopathy. Secondary impetigo also due to constant scratching. So the place where the mite has taken a blood meal gets infected first, and then from scratching with the nail, that infection gets spread to other areas of the scalp, face, and even other parts of the body. A papular eruption can occur on the nape of the neck, where it becomes visible. It's there on the scalp, but it's more visible on the nape of the neck, and it's itchy. Uh, Severe neglected cases where the scalp starts hurting and the patient does not allow combing of the hair can get matted, and that is called plica polonica. Empty nits are maximally seen in the parietal and occipital region. So sometimes we get patients who have got persistent occipital lymphadenopathy and we are not able to determine what is the cause. So one of the uh, causes which needs to be ruled out is a earlier pediculosis capitis, and that can be which may have adequately been adequately treated or may have spontaneously healed because of hygiene practices or family traditional practices, and infestation has got controlled. But nits may remain, and the nits will clinch the diagnosis of what had happened and why the lymphadenopathy is still occurring or is still persisting. Now, nits may need to be differentiated from pseudonits, and that is usually in other dermatitic condition, peripilar casts are there. So sometimes it may need differentiation, but if one is familiar with what nits look like, it is easily resolved. Demonstration of lice by combing of the hair is the diagnostic, right? Is clinches the diagnosis, or demonstrating of the live lice crawling around in the scalp. Presence of only egg cases and nits need not uh, be treated because it does not indicate an active infection. The persisting lymphadenopathy, you might take a decision if it is tender to give some a short course of antibiotics, because usually what happens then is that the bacterial infection which has occurred at the places the mite has bitten, that is carried to the regional lymph nodes and has resulted in the lymphadenopathy. So there might be some persistent bacteria in the lymph nodes, intracellular or antigenically keeping the lymphocytes activated and causing tender lymphadenopathy. Can you hear me? The light has gone out here. Hello?
So
Hello?
we can still hear you.
Okay, fine. Differential diagnosis is uh, other causes of scalp pruritus, seborrheic dermatitis, psoriasis, piedra, which cause also some degree of scaling and itching, or deformity of the hair, or something sticking to the hair like nits. So this is just for theory. Practically, these are easily differentiated. Treatment, of course, pediculocytes. And again, all family members and contacts, ideally, if they're school children, the fellow students, neighboring students, they all need to be treated simultaneously. When nits are left alone, they can be removed using a fine net comb, and this can be facilitated by some hair oil or something which softens the chitin and the knit, like PEG, polyethylene glycol. All materials in contact with the head uh, need to be washed in hot water, about 50 degrees, at least 20 minutes of exposure. All bedding and clothing which has been exposed to the head can be kept in a plastic bag for 3 days. So then what happens is, without a blood meal, the pediculi will die. Combs can be also soaked in hot water. Um, Refractory infection may require oral antibiotic like cotrimoxazole for 7 to 10 days, which also kills off the mite, or oral ivermectin, which is basically a anti-arthropod. Other pediculicide drugs, benzyl alcohol, uh, ivermectin, permethrin 1%, and other pyrethrin piperonyl butoxide combo. So the problem is that uh, all these drugs are approved only for 6 months or older. Fortunately, less than 6 months, children don't usually get pediculosis because their hair content on the scalp is minimal, and it can easily be cut or shaved. So that is also a cure. Pediculosis corporis is infestation of human body and clothing. It's predominantly resides in the clothing, and it comes to the body for a meal. This is uncommon in pediatric age group. Uh, Street children might have it. If you get a street children with intensive generalized itching and excoriation, then this is one thing you might want to rule out by taking a good look at the seams of the shirts and trousers. So homeless refugees, war victims, in natural disasters, it suddenly, there's an increased incidence. And this organism is a vector for typhus, relapsing fever, trench fever. And so uh, it should not, it's a good idea to treat it promptly and eradicate it. Pediculosis corporis, the pediculus on a woolen garment. This is diagram, if you can be appreciated. The pediculus is slightly larger in size than the head louse, and eggs are laid on clothes, so they are not seen on the body. And the eggs do not tolerate high temperature or extreme low temperature, so they are usually laid in the seams of clothes which are in in contact with warm parts of the body. So clinical features is there's severe itching, there are pinpoint red macules and maybe maculopapular. So erythematous papules may be there, and these are areas where the pediculus has taken a blood meal, and it can get secondarily infected and cause a lymphadenopathy. Fecal pellets or blood staining may be seen on clothes because the pediculus secretes or has an anticoagulant in the saliva, which allows the blood to flow freely, and that might get onto the clothes. The adult lives in the clothing seams, and they are in skin contact. The areas which are warm, that is neck, axilla, waistline. Prolonged exposure and scratching results in hypopigmented skin, which leads to the typical appearance of vagabond's disease or morbus erroneum, which is the other classical names for this when it used to be more rampant and more easily or more commonly seen. So clothing and bedding of infested individuals should be discarded in tightly sealed plastic Nowadays we use biohazard bags and either incinerated or soaked in hot water more than 60 degrees for more than half an hour. If not possible, it can be fumigated inside the bag, uh, or laundered using hot water. Hot ironing of the seams can also kill off the adults and destroy the eggs. And the pediculi may stay in furniture, in seams of upholstered furniture also. So those also need to be this thing, otherwise, treated. Otherwise, the infection or infestation can recur. Exposure to untreated infested items should be avoided for 2 weeks. So if you're putting it in a plastic bag and you don't have the facility of either laundering or fumigating or anything, then actually just put it aside for 2 weeks. 2 weeks without a blood meal, it is expected that the uh, pediculi will die, or it can be kept exposed to the cold. And the insect being invertebrates, they don't survive in the cold away from warm body for very long. Oral ivermectin is now becoming more popular. So 3 doses, that means three weekly doses are usually adequate. But you have to remember that the ivermectin will be circulating in the patient's blood, and the pediculi have to take the blood meal and have an adequate dose exposure to get killed. Then pubic lice or crab lice, pediculosis pubis. So this is a minor STI. It affects males more than females. What is meant by a minor STI is that it requires close interpersonal contact for significant amount of time, which usually occurs in sexual contact. So it usually then becomes an indicator that other STI may also be existing in the patient. Their males are affected more because they are usually having larger amount of coarse hair. So the lice attaches itself to terminal hair or coarse, strong hair, and wherever these hair are existing, these are the areas of predilection for the lice. So uh, Asians have less body hair, not everyone, but see, at least the mongoloid, people with mongoloid features, they have less body hair, and they are and with less pubic hair, and they are less affected. Uh, in males who have sex with males, it has got a very high incidence. And it is also sexually transmitted, and it's transmitted by fomites also. So exchange of undergarments can also cause this. And wherever there is thick terminal hair, whether it's the pubic area, eyelids, eyelashes, the pediculi may be seen. And particularly areas where the temperature conditions are good, because all these insects, they are as invertebrates, they can't take extreme temperatures, either too hot or too cold, and the environment has to be favorable for their survival. Clinical features are itching, and uh, this itching becomes more at night and in the affected areas. So axillary area, pubic area, face. On close inspection with the hand lens, lice clinging to the base of the hair will be seen. So out here in this diagram, along the eyelashes, and you can see them in this diagram in the you know uh, pubic hair on the side. And macular cerulae are the areas where these are asymptomatic slate gray bluish macules, where the lice has taken a blood meal, and the blood has then undergone, the residual blood has undergone, uh, you know, degeneration or metabolic degradation to biliverdin and other hemoglobin degradation products, giving it a slate gray or a bluish appearance. Drugs used to treat: permethrin 1%, uh, cream rinse, which is used in head louse, or permethrin cream 5%, which is used in scabies. Both are useful in this condition, and they rapidly kill the lice. Ivermectin tablet also can be given. Uh, so that all are safe in pediatric age group. You have to make sure that the dose is right. Ivermectin is of course not recommended in children who are less than 15 kilos of weight. It's not licensed for them, but off label it has been used with success. All right, so with that I'll stop and I'll open this session to questions.
Thank you, sir. Thank you for your wonderful presentation. Please stop sharing the screen, sir.
Okay, I'll just 1 minute stop sharing.
Most of the questions are related to the commercial preparations like shampoos, etc., which are
Yeah.
available. Are they effective?
No, actually, see, the Crimrin's version of permethrin is effective for pediculosis. I'm having a little difficulty in stopping this. One second, just give me 1
Stop
second.
sharing, sir. Press the green button. Stop sharing.
I pressed it twice. It's mm,
It's okay, no problem.
just wait. It's going only around in circles and share. All right, 1 minute.
So we can still discuss. No
Okay. So, see, basically, as I say, for dandruff or antimicrobials dispensed or delivered in a surfactant background, whether shampoo or soap, these are products designed to fail because the contact period is not long enough for killing the microbe or your target microorganism. Uh, Microorganisms will persist even after application. Particularly those who have entered into the hair follicles, who have gone into the sweat gland ducts, and the in the 3 minute or 5 minute or 10 minute application, the active ingredient has not reached the microbe in adequate strength for long enough. So that's why dandruff treatment is a frustrating treatment because your ability to lower Pityrosporum ovale colonization on the scalp or other parts of the body gets limited by this feature. So it's always better to apply a lotion or a cream and fungal later after doing the shampoo or before the shampoo.
Right. And sir, nowadays that gamma benzene hexchloride is used not.
Yeah, see, for environmentally conscious doctors, it's recommended not to use lindane because lindane has got a half-life, degradation half-life in the environment of 80 years. So after you've applied it for 1 day and you take a bath, it all goes into the drain and it goes into the groundwater or it goes into the river. Organochlorines, that's why have fallen out of favor as insecticides. So permethrin, on the other hand, has a 3 to 4 week half-life. So it
Right,
gets
sir.
degraded spontaneously. So it is a safer option. By treating the patients, you are not degrading the environment.
And so for children with scabies or less than 6 months of age, what is the best option? Glutamate or
Uh, if you have a friendly dispensing chemist, ask them to make sulfur ointment. And if the weather is not cold enough for ointment, a sulfur-calamine lotion. It's available as an acne preparation, sulfur-calamine lotion. It's available in the market. and that is applied for 3 consecutive days all over the body, because in infants, the mite can be everywhere, anywhere and everywhere.
The antibiotics are to be used wherever we suspect skin irritation, not in
Yes,
every.
wherever there is a pustule or wherever there is a bulla.
Okay. And how to differentiate scabies lesion from other skin lesions based on morphology?
See, if you are getting lesions if of different categories, like uh, if you, of course, if you get a burrow, then no problem. But if you get papules, pustules, bulla, predominantly following what is this circle of Hebra, no? That is this distribution: axilla, groin, elbows, interdigital web spaces, uh, pubic area, areolar, nipple areolar area. Then you're fairly certain that at least that you're dealing with clinical scabies. And in our situation, see, right now there is a scabies pandemic going on. It's been going on for actually some decades. It's estimated that
Okay.
200 to 250 million cases occur every year worldwide. So we, in that kind of a situation, we are justified in giving presumptive treatment when clinical features give rise to a suspicion.
Okay. And so ivermectin has to be used in children more than 15 kgs.
Yeah,
Any minimum
actually,
age also,
it is approved for children more than 15 kg weight.
and any
Officially,
age
less than that, it can be used. It works. So far, there is no report of any toxic effect, but it's not given very frequently. It's given rarely, but it's a off-label use, and whoever is prescribing, the doctor who's prescribing, is taking it on his own risk. Or is prescribing on his own risk.
any minimum age also, sir? Great.
No, it is actually, the problem is that it causes CNS toxicity, and it
Yes.
has a huge therapeutic window in humans as compared to invertebrates in mammalian systems. So at a lethal dose for the invertebrates, arthropod or nematode or whatever parasite, it usually is not even having a mild effect on the mammalian system. But there is a weight category that if the dose exceeds a certain amount of milligrams per kg, then it is unpredictable or it's not tested.
It has to be given in weekly doses.
Sorry, I could not hear you.
It has to be given every week,
Yeah,
weekly doses.
eh, eh, sometimes even a single dose is enough, but as a precautionary measure, we recommend in scabies once more at 8 days or 14 days, or between 8 and 14 days.
Dr. Prachi wants to ask something. Prachi, Dr. Prachi, ask you a question. Sir, if a baby has accidentally ingested permethrin, cream or lotion, what should be done?
Okay, that's something which you need to give a stomach wash
Okay.
and watch and observe for neurotoxic effects. Someone
ठीक.
is saying something in the background, but I'm not able to hear it clearly. So if anybody has got a question
Dr. Prachi, you
unanswered,
want to ask something? You can unmute yourself. Dr. Amit, if you want to ask some questions from the chat box.
see, the scabies might, uh, why why you get these mini epidemics every winter? Why you suddenly have a upsurge is because it is very susceptible to heat, light, ultraviolet light. So if someone is sunbathing and the adequate ultraviolet light and infrared light is reaching all parts of the skin, that person cannot harbor scabies. But we can't recommend that as a treatment in winter for infants and children. But if you are able to put the child on an incubator which has got this heat control, that will also remove this, will kill the mite.
Can you just once uh, again explain the application of permethrin? Like, what is the ideal method of that?
See, ideally, it should preferably be applied after a bath, because what happens is that the penetration into the epidermis is improved by in moist skin or in skin with adequate water hydration. And in older children, from the nape of the neck or below the ears till the plantar surface, the whole body needs to be treated, or the cream massaged in, and the whole tube, 15 to 20 grams of it, should be finished off in that application. And then the clothing worn uh, to keep it overnight, that should not be changed till the next bath, because if, as some of it will come off in the clothes need to stick to that part of the skin, so that if the mite comes out of the burrow and tries to move around, it will get treated by the clothes also, by the drug in the clothes. So that will ensure a higher level of success.
And repeat after. Uh,
Yeah, see, the most crucial thing what happens in our country is that some members of the family are in incubation and are not perceiving any itch. They don't come forward and take any treatment. So contacts, everybody doesn't take treatment simultaneously. So that usually leads to, that's the most common cause of failure. So most derma departments, residents, get trained and forcefully inform the patient that the whole family needs to take treatment, even if they are not feeling itchy or scratchy. And whether you don't need to ask them whether they're itching or scratching. You just tell them that ek din ye lagana hai.
Dr. Vidya, Dr. Amit, there is more question. Any you want to elaborate on?
I guess, sir, more or less all the queries are answered. But somebody was asking that the use of oral permethrin during COVID times. So, what is the role of effect of this ivermectin over the scabies and pediculosis, which was used during COVID? And indication, as sir already showed in the slide, that indication of oral permethrin and its role in infants of less than 15 kg. So it is contraindicated in infants. And over to you, sir, for this COVID question.
See, basically, I think there's a slight confusion between permethrin and ivermectin. So, ivermectin was one of the therapeutic modalities which was pushed underground by FDA during COVID times. But COVID times, we really stopped seeing scabies and pediculosis, so it's hard to really put a figure onto how successfully scabies or pediculosis got eliminated because people were dosing themselves on ivermectin. So I don't have any hard figures, and I don't have, I'm not even aware of any clear-cut study about this. But yes, if somebody is taking a single dose of ivermectin a week or twice a week, that person, and it's adequate to cover COVID, because the COVID dose is slightly higher requirement, then they are unlikely to have, get infested with either scabies mite or by pediculi.
Hydrate is a popular product for pedic. Your take on hydrate?
Dr. Ajay, please say it again.
Hydrate. HEDRI. Popular product for pedic.
You will have to tell me the drug, pharmacological name.
Dr. Jayakumar, can you elaborate what is the content? There are no more questions. Most of the questions have been answered, and there's still some more queries. Post them in the group. And what is
Is
the
there any
treatment
other things like cutaneous lava migrans or insect bites, papular urticaria? I mean, see, there are also effects of parasites or infestations, not really strictly infestations, which I've left out of this talk. So if there are any questions, I can answer that.
treatment of nodular scabies?
See, nodular scabies is that after you've given adequate treatment for the mite and you're sure of the compliance, then depending on the age of the patient and the location, a moderate uh, potency steroid or just a potent steroid may be added topically on the nodules to make the nodules subside, because these collections of lymphocytes may continue to cause itching, problematic itching in some patients. But that is the caveat is that the scabies infestation has to be adequately treated.
And the treatment of larva migrans, duration and how to identify.
Yeah, okay. So if you are sure about the which organism it is, albendazole, yeah, or topical thiabendazole or albendazole orally, because these are usually nematohelminths, so is adequate. Now, depends how long you will give and what will be the dose would depend on the accuracy of your the species diagnosis. But if you are giving, say, 400 milligram in adult, 400 milligram tablet of albendazole for 4 5 days continuously, usually most of the cutaneous lava migrants due to the helminths which cause hookworm or the abdominal helminthiasis, they are adequately treated.
Doctor, want to ask something? Unmute yourself and ask.
Sir, I just want to ask regarding one thing. Suppose we have a scabies infection along with eczema like thing. So in such a situation, when there is a confusion, when we need to use the topical steroids also, and how to go about in such a situation? Should
So,
we? Yeah.
my advice to you would be to treat the scabies first, uh, because it's only a overnight application, and a patient with inflamed skin, the penetration of the permethrin will be faster because already the skin barrier function is compromised. And from the next day, you can add the steroid topically.
So in that case, should we repeat again the permethrin application?
You can take a call on this on the 8th, between 8th and 14th day.
Okay. Sir, and one more thing regarding ivermectin, does it have any residual effect in preventing sort of controlling the scabies once you have given it a therapy? I- Is it having anything of that sort that
No,
then?
and the thing is that uh, the ivermectin in scabies also, it goes into the mite which is taking active feeding, because it penetrates into the tissues, and in the living tissues it is there, and the mite which is taking the keratinocyte feed and the serum interstitial fluid feed, gets dosed with the ivermectin. The eggs don't get affected. So one of the reasons for giving the second treatment is that if there have been eggs which are viable and which hatch, then on the 8th to 14th day, you are giving a second round of treatment. So the eggs, because they are just inert, they are not taking any feed or anything, and nothing is going into them. So they might survive.
Right. So one more thing regarding if a child is having a scabies, now how to go about treating the family? Is there any protocol for that?
Yeah, everybody takes the treatment, at least the topical treatment on one day. If the person says that why should I take it? I am not feeling itchy. I don't have any eruptions. The patient and that person may be asymptomatic. The DTH might not have developed. So you have to persuade that patient that this is for your child's welfare, and you don't have to take any tablets, antihistamines or anything because you are not feeling itchy. But the application that when we applied on your child, the mite might escape to your body, so that it doesn't escape to your body and it doesn't come back. We are trying to eliminate it from your household.
Right. So and once a
Pediclosis on eyelids. Eyelids.
Sorry.
Pediclosis on eyelids. How do you?
Yeah, so you can use the this thing, forceps and remove each of the few eyelid pediclosis and put tetracycline ointment, or you can put over the closed eyelids permethrin cream, a little for a half an hour or an hour and wash off. That is usually more than enough to kill the the pediculus. But the problem is that the eggs might survive. So you might need to revisit it once more.
Right. We have answered most of the questions. Thank you very much. We'll have a break on the 31st of December. We'll meet again on 7th of January.
Okay, thank you so much for your patient listening.
Thank you all the delegates and thank you all the faculty who have joined. Rampura teacher, and
Okay, bye,
coordinators,
thanks.
Dr. Vijay Yadav and Amit. Thank you.
Thank you,
Mr.
sir.
Sushil, please close the seminar. Mr. Sushil.